It will be safe. It will be safe. Okay? So we cannot give 0.65 inspiratory time and rate of 35 and IE of 1 to 2 because there will be no time. Okay? So let's say 1 to 1. You understand? So let's say 35 and 1 to 1. So we said the inspiration is 22.75. Okay? Plus 22.75. Just write it. 22.75 plus 22.75. So this is how much time? 45.5. This is the time for inhalation and exhalation. The remaining time for pauses. So the baby will be relieved. He can pause. He can stop breathing. You understand? So if we're going to do, if you want to do 1 to 2, you either decrease the inspiratory time or decrease the rate. You cannot do both because you exceed the time. So let's decrease the inspiratory time to 0.5. Even 0.5. Let's say 0.4. Okay, now let's repeat. 35 times 0.4.
35 times 14.
0.4
No.
0.40. 14.
14. If we put the rate 1 to 2, so the exhalation will be 14 times 2,
14
28.
times 2, yes.
28 plus 14, the inspiration,
Plus 14, 42.
42. So we have 42 both for inhalation and exhalation,
And the other
and we can
rate.
make the IE ratio 1 to 2. So
The other
the idea
also.
here, you have many parameters, but you only can select 2 because you have the time fixed. So if you select rate and inspiratory time, the expiratory time will be by default.
Yes.
You understand?
Yes.
Now, if you select the time and IE ratio, the rate will be by default.
Yes.
If you select the rate and the expiratory time, the IE ratio will be by default. You cannot select all because the time is fixed. That's the idea. Okay? So now when it's not possible, this will not be possible. Make sure that you understand this. So sometimes you cannot, ventilator will not make you the rate if you put the IE ratio different. Clear? So this is the rate. You understand what is the rate? Some people call it backup rate.
Yes.
It's the number of ventilation will be delivered by the machine. While the rate here you see both, or everything, assisted, spontaneous, and the backup rate. So this is called backup rate. This is the inspiratory time, the inspiratory pressure, maybe the delta, I'm not sure, I'm never used one. So let's say, so pressure is, this is the room air. What is the starting room air? This is the FiO2, the oxygen percentage. What is the starting? Always room air, 21%. Why we start with 21%? Because Allah created us in 21%.
Yes, it's
Okay?
toxic.
We don't have scavenger. We don't have from our body something to remove the oxygen radicals, like O, like O2, H2O2, because it's only HO2. Okay, O3. We cannot remove it. We are not like the fish. So you cannot give a human being more than 21% for a long period of time because they will die. So you cannot in corona patient, like what I see in Iraq before, you give pure oxygen to the human being because after 48 hours they will die. You cannot give pure oxygen. Why? Because we don't have the scavenger to remove. What is the scavenger? For example, hemopyroxine. We don't have hemopyroxine to get out, so it will start to accumulate in the brain. What is caused? Encephalitis. In the heart, cause myocarditis. In the lung, cause pneumonitis. In the kidney, cause nephritis. In the bowel, cause enteritis. And then you get multi-organ failure and you die. So then what you should do, you always give room air. But if we need more pressure, what you will do? You will give air. And then you should have air oxygen blender. So that's why no oxygen without air oxygen blender. If you remember the oxygen delivery,
Humidified, heated,
humidified, heated, and blended.
Yes.
So always start with room air. Now if the nerves, but you have target saturation on the monitor, you need to achieve it always. So temporarily you can increase until you come and discuss what is the problem. Is it improper sedation? Is it improper analgesia? Is it wrong mode? do you have a fault in the tubing? Do you have problem in the patient? Do you get pulmonary edema? Do you have pneumothorax? Do you have obstruction? Do you have secretion? Do you have patient fighting the ventilator? So you have to, do you need a surfactant? Do you need a bronchodilator? What exactly happening to the patient? Then you have to support. So you might escalate the support and then you always have to go back to room air. So once you need FiO2 more than 30% for more than 15 minutes, there is something wrong. Either you or the patient or the machine. So never ever give oxygen more than 30%, even if you are adult. So it should be heated, humidified, blended, and it should be room air. Is you understand? In a premature baby, we start with 30%, according to American Academy of Pediatric Guidelines, or the ALCOR, which is the program, the NRP, neonatal resuscitation program. We understand this? So that does not mean you don't give more FiO2, but you give temporarily until you solve the problem. How? You escalate the support. So if you are on CPAP, you go invasive ventilation. If you are invasive ventilation, you go high frequency. You might need ECMO. You might need sedation. You might need analgesia. You might need diuretics. Okay? You might need muscle paralysis. You might need antibiotics. You might need hemodynamics changes. You might, and so on. Is that clear? So we have FiO2. We have the PIP. PIP, we only set it if the control is pressure control. Because in volume control, we cannot set it. Okay? And then we have the rate. Now we understand the backup rate. And then we have the inspiratory time. We understand it. We have the PEEP. And then the PEEP are many types. We talked about it. Applied PEEP, internal PEEP, auto PEEP, external PEEP,
Yes.
and so on.
Affected
Best
PEEP.
PEEP, we'll talk about best PEEP later.
Yes.
Okay? And this one, assisted or not? Yes. So we can tell the patient, off, don't help. Like,
During weaning and
it's not working. It's failed because he's helping. See? Oh, only if we exceed the result. See, it's not helping.
Irregular wave, we will see.
Because we tell them off.
Off. Assist off.
وإذا كان ضمن regular cases ده
أجرب الرجل هنا سيست أزوج الرجل
يؤوني كبير.
increase
Of course, I should do it very minimum. So it
So
won't
with assisted, the pressure wave will
So
be
not assist.
regular.
Yeah. Okay? And this is the trigger. Is how much the patient, so we can change it to flow. I don't know if we can change it to flow.
Doctor, in which conditions we make the assisted off?
This is a flow trigger. We don't use in babies flow trigger. We always use a pressure trigger. You can see flow trigger. Liter per minute. Yes. Ask.
In which condition we make the assist off?
And by when we
which mode there is no
weaning,
assist? Remember it? Yes, when we took the lecture.
يعني
Controlled mandatory ventilation, CMV. When we choose the mode, CMV. Okay? So this one is there is no CMV. So if we turn it off, it's a CMV now because there is no support. Okay? Now clear? I don't expect you to know everything. We know this.
no.
We know this.
We
Okay.
don't-
This
we don't
one
know
is
this.
what's then?
dependent
P peak.
P
How much the machine is giving. Okay? P peak. The pressure peak. How much the ventilator giving. It's a result of on this and the patient interaction to achieve the accepted tidal volume.
but this is doctor not too much 20
20 or too much for what?
يعني for PEEP
This PIP, not P.
PIP
P is 6.
excuse
for 3 to 4.
P mean is how much? Is the this is the mean airway pressure.
من airway
How much?
pressure
Map.
7
7. So
10
this
to
is,
15 it is
yeah. So this is low.
The peak one
Okay.
and 10 to
This one.
PEP.
So what's the difference between
More
this
than
PEEP
five.
and this PEEP?
It's by the patient.
This is dependent.
And
This is
this is
independent. This is
independent.
dependent. You understand now?
yes
Okay. This is minute ventilation.
yes minute ventilation
This is the FiO2. How much going? We are not giving FiO2 now.
Yes.
This one is tidal volume total. This is tidal volume out versus tidal volume in. This is adult ventilator. Don't worry about it. I'm just giving you the principle. When we take the neonatal and pediatric ventilator, it's different. It's different. And this is portable, also different. So but I'm just giving you the principle. Now let's go to another mode. Pressure, SIMV.
Pressure is
Okay? So what is the difference here when SIMV? Look at me.
Need less support.
Synchronized, intermittent, mandatory ventilation. There is no assisted here. But they will never go against each other. You see? So not all assisted. Look, not all assisted. You see? Assisted only when the rate is coming. So because they don't fight together. You see? You see that we see one here, one, and see. So in this mode, we see what? Mandatory and the spontaneous. We never see assisted because it's intermittent, mandatory ventilation, SIMV. It's a mode below the AC. It's the mode that the patient is contributing. Okay? So we give less support for the patient. Why? Because the spontaneous, the patient has to do it by himself. He will never be supported. So it's more difficult on the patient. Okay? That's why when the patient have high low CO2 and he's on AC, I'll tell you, move him to SIMV. Because let's say the patient is breathing 60 beat per minute and the rate is 35. In AC, how much the measured rate will be? So the patient is breathing 60. The ventilator is 30. And the patient is breathing 60. And we are on assisted control. What is the measured rate will be? 60. So the patient is breathing 60. And the ventilator is 30. Or we are on SIMV mode. What is the rate will be? 30. You understand? So it only will provide the mandatory, not the assisted. You understand the difference? Or no?
No.
Okay. Assisted control regarding the breath. Which breath you will see?
What do you mean?
We have so many types of breath.
3.
Okay. In assisted control, which type you will see?
Assisted.
Assisted and
Control.
and the control, the mandatory. Okay. So let's say the patient, the rate is 30. What is this 30 here? Mandatory. The control,
Yes.
the backup.
Yes.
Okay. And this is the assisted.
Yes.
Okay. So let's say the patient is breathing 60 times. How much the rate will be here on assisted control? 60.
Yes.
Okay. Let's say the patient on intermittent mandatory. How many types of breath you will see in intermittent mandatory? Of the 3. Which one?
Mandatory
And
spontaneous.
Spontaneous. You will not see assisted.
Yes.
Clear?
Yes.
Okay. So let's say the rate is 30 and patient breathing 60. How much the rate will be in intermittent mandatory? Will be 30. It will not be supported. So it's more difficult on the patient. No. So now let's say the patient have low CO2 and he's breathing 60 while on SIMV is breathing 30. Which one will be washing more CO2? The rate high or the rate low?
Rate low.
Rate high.
High.
So that's why when you have low CO2 and the patient is breathing 60 and you are on assisted control, we switch to SIMV. You will learn that in the future, but just that's the difference between SIMV. The rest are the same. In SIMV, there is no assist. There is only spontaneous
And mandatory.
and mandatory. In assisted control, there is no spontaneous
Mandatory
and assisted. Clear?
Yes.
And then we have PSV and CPAP. Here, pressure support ventilation. This is the mode. Okay? The difference here, it's the same like SIPBV or assisted control. But instead of time control, it is flow control. You understand? That's the difference. What is flow control? So in time control, we set the ventilator, breathe in within 0.35 or 0.4 or 0.65 seconds. Okay? So you do in within this time. You understand? That's called time control. In flow control,
We say
to the ventilator, measure the flow created by the patient in the previous cycle.
Yes.
And if it meets a criteria, give him the second one.
Yes. Must be 25%.
So let's say if we tell 25. So when the patient achieves 25 or previous, the next will be supported.
Yes.
And if the patient, we said it 25, and the patient achieve 30, will be supported.
Yes.
If the patient achieve 20, will not be supported.
Yes.
25%. So the ventilator measure the flow of the previous one and support. But it will not, the baby will determine over how long he will do it. There will be no time.
Yes.
So it's flow control. While in the first two modes, it's a time control. We tell the machine that when you support, give it within this time. You understand? In PSV, no. It will be support, but it will give open time for the patient to do it. But it will support only if the patient achieve 25% of the previous cycle. Otherwise, second one will not be supported.
Yes.
That's called PSV, which means the baby will drive the machine. You understand? But what is the problem with that? Let's say you have a driver, and the driver is drunk, sharab kahul. Will he able to drive? No, exactly. So when you give sedation, we cannot give PSV. It should be without sedation. One. Second, if the patient get tired, let's say you are a driver and he drove for 24 hours, will be able to drive? No. So when the patient is sick, we cannot give PSV, like a premature baby. But we can give it for 24 hours, whatever the driver can tolerate, and then he will get tired. So that's the PSV. First, the patient should be not tired. Second,
Not
should be not sedated. If you give it, what will happen? Either you make accident, or you stop. You have to stop aside and stop driving. Okay? So the baby will either stop breathing, okay, or it will be what? Will be exhausted. And that's the PSV. So we use it only when the patient is capable, not sedated, and not so. And then for a certain period of time. We cannot give it
More than 24.
for example, 24, 48, depends on the patient. But it should not be for long. If you keep doing it, what will happen? The patient needs more energy. Even if patient do it for a long time, he will start losing weight. And that's why when I come in the morning, what's the weight? I will ask the first question. What is the weight? What's the weight? What's the weight? What's the weight? You look, weight, obsessed with weight. Because if the weight is not gaining, we're not doing a good job. And we'll have a target. We have to achieve the birth weight by day 7. We're doing very good. If we achieve the birth weight by day 14, then we're doing fairly good. If we achieve the birth weight by day 21, then we have very poor, bad performing unit. So that's why the weight is very important. And we'll talk about it later. Now, do you understand the PSV? It's like the same of assisted control, no difference. But assisted control is time control. This is flow control. What is meaning that we will tell the ventilator, give the inspiration, which is 30 within 0.4. Clear? While in PSV, we'll tell the ventilator, give this rate, whatever the patient done, if he can do for the previous cycle 25% of the flow. If he achieves 25 and more, help. If he cannot achieve, don't help. However, we cannot leave it open, otherwise the patient will stop breathing. We have to put a backup rate. And to give time for the patient to build the flow, we make the backup rate very long. So we have to, if we go PSV, we have to go to this and make it very prolonged. But that does not mean the patient will make 0.7. You understand? But if he couldn't do it by flow within 0.7, the machine will help.
Yes.
So that's why in PSV, we give it only for strong patient. We don't give it for long time. We don't give it for sedated or comatose patient, and the inspiratory time should be prolonged. صعب؟ لو فهمت شوية. صعب. It need time. This is your first session. Okay? We need repetition and need
And then we
by
understand.
cases, and then you understand, and then you start to ventilate, how to ventilate asthmatic patients, how to ventilate bronchial, how to ventilate heart failure, how to ventilate RDS, how to ventilate premature, how to ventilate meconium aspiration, how to ventilate congenital diaphragmatic hernia, and so on. You will learn. It's tricks, you will learn it. But it needs time, and you need to work with me.
Inshallah.
And you need
We
to
are
stick to the
ready.
patient. Okay? And you will learn that most of Erbil people, that they work here, just stop the recording.